Hello, everyone, and welcome to today's webinar, Laboratory Testing for Viral Hepatitis. What's new and what has changed? I'm Sabrina Lemus of Labroots, and I'll be your moderator for today's event. Today's educational web seminar is presented by Labroots and brought to you by Diasorin. To learn more, you can visit diasorin.com. Let's get started. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them into the Ask a Question box and click Send. Any questions submitted today will be answered via email following the broadcast. If you have trouble seeing or hearing the presentation, click on the Support tab found at the top right of the presentation window, or report your problem by clicking on the Ask a Question box located on the far left of your screen. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located on the top right of the presentation window and follow the process to obtain your credits. I now present today's speaker, Dr. Robert Gish, adjunct professor of medicine at the University of Nevada Schools of Medicine in Las Vegas and in Reno. For a complete biography on our speaker, please visit the Biography tab at the top of your screen. Dr. Gish, you may now begin your presentation.
Greetings. Thank you for joining us today. This is about stopping hepatitis in celebration of World Hepatitis Day, July 28, 2020. Laboratory testing for viral hepatitis, what's new and what has changed. I'm Dr. Robert Gish, based in San Diego. I teach at a number of other institutions, including Loma Linda and University of California, San Diego. Our agenda today: viral hepatitis overview and guidelines updates, focusing on hepatitis C and hepatitis B. Within hepatitis B, we'll be looking at serology, disease state, hepatitis B E antigen and E antibody, and also talking specifically about hepatitis B surface antigen. What is the status of hepatitis B and C in the US today? Well, this is looking back a little bit, and also we're going to talk about looking forward. There is a goal for elimination of hepatitis B and C in the US by 2030, but we're not really on target, unfortunately. You can see with a little red X mark on the right side that we have increasing acute hepatitis B infections, as we're seeing with hepatitis C infections. This is because of the opioid epidemic and problems with implementing effective harm reduction. We are decreasing the rate of hepatitis C-related deaths and hepatitis B-related deaths because we have more active testing and more linkage to care. Hepatitis guidelines, these are from the CDC, in alignment with AASLD and the U.S. Preventative Health Services Task Force. What about hepatitis C? This is curable, but there's no vaccine, but it's also preventable with harm reduction and a clean blood supply. Our updated guidelines now are to test all adults, all pregnancies for hepatitis C, at-risk individuals, so we're still taking a risk history, and in at-risk individuals, we'd be testing basically annually. Hepatitis B is vaccine preventable, but not curable, but we can suppress hepatitis B and change outcomes, decreasing death, liver transplant, liver cancer, liver failure. And importantly, with both hepatitis B and C as infectious diseases, we're going to be decreasing transmission by testing and linkage to care. The Institute of Medicine started talking about changing outcomes in 2010, advocating for screening for viral hepatitis to be part of the primary care provider assessment algorithm. In at-risk individuals, now test all adults for C. Hepatitis B is not quite as general, although the Hepatitis B Foundation, where I work, is advocating that all adults be tested for hepatitis B using the triple hepatitis B panel. We'll talk about that in a moment. We have very effective vaccines. And in fact, we have a 2-dose vaccine that is at time 0 and time 1 month with a much higher antibody response rate, and with 2 doses, better compliance. That's very important, thinking about these corona times and minimizing the number of times some individual needs to come to clinic. By decreasing transmission, we'll have fewer carriers and fewer onward transmission of viral hepatitis B and C. Gaps exist. Fortunately, over the last 2 decades, we've become very good at testing for HIV and linking to care. Hepatitis C and B, as you can see in these big circles, these Venn diagrams, is we have prevalence data, but diagnosis and treatment to care, a marked decrease or a marked lack of those 2 next steps. So let's get on board with the WHO efforts, our own national efforts, international programs of testing, screening, and linkage to care. Let's talk about an update on hepatitis C. We still have a lot of work to do. Treatments are available, but fortunately the cost has come down to about $20,000 to $30,000 per cure, which is absolutely amazing. This is not only cost effective, this is cost savings. But we have this problem of increasing number of hepatitis C acute infections and subsequent chronic disease. We need to be preventing those, but testing and treating even acute hepatitis C. The reduction needed to meet a 2020 goal where we're sitting today is 76%, and we're not there. But we're going to be getting there, I think, over the next decade with everybody's help. Why test for hepatitis B? Well, this is a very serious problem worldwide. 2 people die every minute from complications of hepatitis B, cirrhosis and liver cancer. We don't have enough liver transplants to go around. We can prevent B with a vaccine, and we can treat people who are chronically infected by suppressing virus, not curing the disease, although sometimes we use the word functional cure. Just think about this, 1 million people dying every. It's time to test and link people to care. A little bit more on hepatitis B testing. The Preventative Health Services Task Force, high-risk screening, increased risk screening, they may be modifying their recommendations to test all adults in 2021. I definitely hope so. How do we get to elimination if we're not testing everybody? And we don't just test with a single test. We need a triple panel. I'll describe that triple panel in just a moment. Our Hepatitis B Foundation has been advocating for years to test all adults. And in fact, we have an interesting new method of communication called Know Your ABCs. Know your hepatitis A, B, and C status. You could even say with that C, you could have 2 Cs, which is the coronavirus. Risk-based testing is not efficient. We have proven that over the years. That's why they went to testing all adults for HIV, and now all adults for hepatitis C. We should be doing the same for hepatitis B. More to come. Tests used to screen for hepatitis B, as indicated here, is this triple panel. Hepatitis B surface antigen indicates infection, linkage to care. Core antibody equals exposure. This is a very specific test with a false positive rate of only 2 per 1,000. So if you see core antibody, you know exposure, you know that patient has CCC DNA in their liver. Even after acute disease, people in clear surface antigen, CCC DNA remains, according to research in peer-reviewed publications. Anti-HBs indicates immunity if core antibody and surface antigen are negative. There is no such thing as natural immunity. We need to get that term out of our lexicon. Once you're exposed and infected, like many other DNA viruses, that virus persists in almost every single patient. I am hopeful for a cure someday because we have all sorts of new technology, but I think that's about a decade away to be able to get rid of CCC DNA and even the integrated virus. Isolated core antibody positivity could indicate a cold hepatitis B. And in those patients, we think about testing for HBV DNA. Using current epidemiologic Terminology in the US: surface antigen positive equals infection, HBV DNA positive equals infection, even if surface antigen's negative. And that is current and state of the art. The core IgM antibody is seen at high titer in acute disease, but could be seen at low titer in chronic disease with flares. So sometimes we make mistakes with that test interpretation. It would be nice if we had antibody titers when core IgM was reported. These patients who are core antibody positive alone do not need hepatitis B vaccination. There are no peer-reviewed publications that show a clinical benefit of boosting, trying to get surface antibody up, increase, positive in this patient population. This is a nice graphic about natural history of hepatitis B and where we're thinking about treatment. It's pretty simple now. We're treating most people. Replication, HBV DNA quantification. If it's over 2,000, we're thinking about treating. ALT above 25 in women, above 35 in men, we're thinking about treatment. We also assess for fibrosis in our patients. We can do that with non-invasive tests today: APRI, FIB4, FibroScan, other tools. Increased fibrosis, also we're thinking strongly about treatment. So now we're turning things around and saying, why should we not treat? What patient population should not be seeing an antiviral agent? And that's relatively few if the patient's replicating, especially with the enzymes being even at the upper limits of normal. So think about these phases. This is very important to know about the natural history and think about how hepatitis B evolves. This is a very important slide that brings up to us new terminology. These are the new EASL terms that I find very attractive and what I apply in my practice. If somebody has a normal ALT but high DNA, we're going to call that chronic infection. We used to call it immune tolerant, but we're not using that term anymore. E antigen positive with elevated liver enzymes, elevated DNA, chronic hepatitis. Next phase, they lose E antigen, DNA falls somewhat, but ALT also goes back into that healthy range that we talked about, back to chronic infection. Then we have an E antigen negative phase with more active disease, elevated ALT, DNA still positive, chronic hepatitis. I really believe these are the most useful ways of putting our patients in specific categories. Let's now talk about perinatal HBV transmission. Mother-to-child transmission is responsible for 1/3 of all HBV infections worldwide. In our country, we should be down to 0, but there's about 1,000 cases a year of babies acquiring hepatitis B from their mothers and being chronically infected. The higher the DNA level in the mother, the higher the risk. Being E antigen positive, higher risk. Higher surface antigen levels, higher risk. These surface antigen mutants allow the virus to escape. Vaccine stimulated immunity, passive immunity through hepatitis B immune globulin administration. So we need to make sure that our hepatitis B tests are sensitive and able to detect these surface antigen mutants. These surface antigen mutants can also explain OBI, occult hepatitis B infection that we talked about earlier. System failures. If mothers aren't tested, high-risk mothers are not offered antiviral treatment if their viral load's over 200,000 during the 3rd trimester. If infants don't receive vaccination, they say within the first 24 hours in the guidelines, then within 12 hours. A recent study that was performed in Thailand suggested that if we give the baby the vaccine within 2 hours of birth, we might not even need an antiviral therapy for the mother who has high viral load. HBig is expensive. It's also another injection, may be missed in terms of administration. Early vaccination may decrease the need for HBig administration as well. Babies born to surface antigen mothers should be tested between 6 and 18 months after delivery to see what their hepatitis B status is. Prevalence of chronic hepatitis B in the US, really the number we think about is 2.2 million. And here are special populations: people who inject drugs, homeless, veterans, HIV or hepatitis C infections, looking for co-infections. We discussed newborns born to surface antigen positive mothers, Department of Corrections, incarcerated individuals, history of incarceration. Healthcare professionals, of course, also need to be assessed. Prevalence of chronic hepatitis B in the US is outlined here. We're going to use the number 2.2 million for the moment. What we show here on this left and right graph, left is the general, right, Asia Pacific Islanders, is a small number of individuals, both with known, meaning tested for hepatitis B, diagnosed and receiving treatment. We think that at any given time, only about 100,000 individuals are on treatment for their hepatitis B with a nucleoside or nucleotide analog. We think that number should be much higher. We think about replication, fibrosis, or elevated liver enzymes. Hepatitis B impact is highlighted here. The impact of hepatitis B is further detailed on this slide. You think about this evolution to cirrhosis or liver cancer. I describe to my patients their lifetime risk of cirrhosis ranges from 15 to 40%, higher for men than women. Same for liver cancer. Give a general number of about 7%, but it could be as high as 15% in men, 3 to 4% in women. So hepatitis B can go through reactivation, compensated cirrhosis, decompensated cirrhosis. By treating decompensated cirrhosis with nucleoside or nucleotide analogs, you can often reverse their function, the decompensation, and sometimes you can take cirrhosis backwards to a non-cirrhotic state. Of course, we're very concerned about patients dying or needing liver transplants for hepatitis B. E antigen and E antibody help describe what phase of disease that patient is in. Earlier phase is called a wild type virus, and later, through mutations and immune pressure, there are core and pre-core stop codons, stop mutations, where E antigen levels fall, may disappear, not being measured directly, and DNA levels can fall slightly, but the DNA and virus replication may be ongoing. This disease, the E antigen negative disease, is a little harder to treat in the sense that the chance of surface antigen loss, that term functional cure, is less likely to happen with nucleoside or nucleotide analogs. We're approaching both populations with our newer therapies that are in research right now. Both disease phases, stages are very important to understand and very important to treat. Hepatitis B surface antigen is expressed by a moderately conserved region of the hepatitis B genome. When we say moderately conserved, that means that that area can change, mutate, and make antigen, surface antigen, that we don't detect with our standard antibody to antigen test kits. So when we are developing tests, commercializing, bringing tests to clinic, we need to make sure our test is broad-based. It can detect as many of these S antigen variants as possible, because we want to know accurately our patient's hepatitis B status. We need to know that in terms of vaccination, maybe even help us in terms of developing new vaccines later in the future in case we have these escape mutations and they become clinically important. The innate and adaptive immune response is very important for both acute and chronic hepatitis B. We use this term now, immune control. We use it in two different ways. One is very good immune control happens when the DNA is lower, S antigen is falling, E antigen may be clearing. We also use the word immune control when we find a patient to be core antibody positive and surface antibody positive, but surface antigens negative. This immune control means a more active, robust immune system, keeping viral replication to the lowest level possible. That immune control typically means a better prognosis, a lower risk of progression to cirrhosis, cancer, transplant, and death. I'm now going to walk through some comparisons about mutations between acute liver failure and those with chronic hepatitis B. There are several mutations in this MHR region, including this Y134 and P120, that have been described to lead to the emergence of escape mutants. This has been seen also with monoclonal antibody treatment. This is in a special setting of immune suppressed patients after liver transplant. And these immune variants became very replication competent and actually led to liver failure in some patients. It's also been described with HIV, hepatitis B co-infection. So when the immune system has less immune surveillance, these mutants can also undergo immune escape. This may explain some vaccine failure cases, some immune globulin failures, and failures of assay detection of surface antigen. This mutation process may be more prevalent in liver cancer cirrhosis cases than in asymptomatic or pre-cirrhotic individuals. This was also published by Zhang in Chinese patients, as well as Coppola. This was significantly detected more in HCC cirrhotic than in asymptomatic or pre-cirrhotic individuals. They then looked at acute liver failure specifically. In the acute liver failure population, there was significantly higher mutation frequency in this A determinant than in chronic hepatitis B. These mutations are genotype specific and occur at a higher frequency in the major hydrophilic region and are associated with higher viral loads and lower anti-core IgM titers. In this acute liver failure, coexistence with anti-HBs can be seen. So some patients have surface antigen and surface antibody. We sometimes can explain that by these S antigen mutants where the antibody that is present isn't binding the surface antigen. Outcomes do not necessarily differ between the groups with or without mutations in terms of some specific clinical outcomes. This is comparison of mutations between the acute liver failure subjects and those with chronic hepatitis B. This is the acute liver failure study group registry. Mutations are highlighted below. 62% of chronic hepatitis B patients and 76% of hepatitis B ALF patients. Let's now wrap up with some conclusions. Hepatitis B and hepatitis C are prevalent in the US and major healthcare problems, actually resulting in more deaths than HIV, malaria, and TB. Hepatitis B virology is complicated. The immune interaction with the virus is also complicated. E antigen and E antibodies are markers of phases of the disease and important for monitoring patients, natural history, and on treatment. Hepatitis B surface antigen is definitely the most important marker because we need to assess infection status, infectivity status, need to link to care. But we've had lots of clarity on core antibody and surface antibody as well. We need to make sure our tests are highly sensitive and can detect patients with S antigen, even if they carry these S antigen-related mutations. Thank you for joining us today, this important presentation.
Thank you again, Dr. Gish, for your time today and your important research. We would also like to thank Labroots and our sponsor, Diasorin, for underwriting today's educational webcasts. Before I go, I would like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today and those submitted during the on-demand period will be addressed by the speaker via the contact information you provided at the time of your registration. The webcast can also be viewed on demand. Labroots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.